Hello, my name is Justin Dino. I am a PGY2 internal medicine pharmacy resident at OSU Medical Center. Today, I'll be presenting my research project, which evaluated dolutegravir lamivudine versus bictegravir intracitabine tenofovir alafenamide, or BF-TAF, as immediate antiretroviral therapy for newly diagnosed patients with HIV. Immediate antiretroviral therapy, or immediate ART, refers to the initiation of HIV treatment as soon as possible after diagnosis and pending results of baseline testing to reduce time to viral load suppression. Current recommended single tablet regimens for immediate ART are very limited. For example, BF-TAF is generally well tolerated. However, TAF has been associated with increased LDL, cholesterol, and greater weight gain when compared to TDF-containing regimens. Meanwhile, clinically significant drug-drug interactions may preclude the use of boosted darunavir, FTC, and TAF. Dolutegravir lamivudine is a well-tolerated two-drug single-tablet regimen for the management of HIV in certain treatment-naive patients. Questions remain in terms of its use for immediate ART due to concerns for transmitted resistance and inadequate hepatitis B virus activity in co-infected individuals. However, evidence supporting dolutegravir lamivudine's use in this setting is growing. My aim statements include contributing to growing evidence supporting dolutegravir lamivudine's utility for immediate ART and expanding guideline-recommended single-tablet regimen options for immediate ART. This retrospective cohort study was conducted at OSU Internal Medicine Specialty Services Clinic, a Ryan White HIV/AIDS program medical provider. Adult patients with confirmed HIV diagnosis initiated on dolutegravir lamivudine or BF-TAF within 14 days of diagnosis with a documented clinic encounter were included. Patients were then excluded if they've received greater than 5 doses of effective ART prior to the encounter, if they've met all guideline recommended criteria prior to dolutegravir lamivudine initiation, if they have no documented follow-up laboratory or encounter at 4 to 8 weeks, or if they've had an ART change not due to resistance or HBV co-infection. The primary outcome was HIV RNA reduction at 4 to 8 weeks, and secondary outcomes included the proportions of patients with HIV RNA at least 50 copies per mil at 1 year, and proportion of patients warranting ART modification within 1 year. 221 patients were assessed for eligibility, and 15 patients were included in the dolutegravir lamivudine cohort, and 29 patients were included in the BF-TAF cohort. Baseline characteristics were very similar across both cohorts. Most patients were male, non-white, and have several HIV risk factors. The mean time between HIV diagnosis and initial encounter was 7.9 days for both cohorts. There were also 0 patients in the dolutegravir lamivudine cohort that had a chronic HBV infection. 47% and 38% of patients were HBV immune in the dolutegravir lamivudine and BF-TAF cohorts, respectively. And among the patients who completed genotype resistant testing, none of them had any mutations of interest detected. When referring to the primary outcomes, the mean HIV reduction at approximately 4 to 8 weeks, measured in log 10 copies per mil, was negative 2.9 and negative 3.1 for dolutegravir lamivudine and BF-TAF cohorts, respectively. There was no difference between proportions of patients with HIV RNA, at least 50 copies at approximately 4 to 8 weeks. And while patients did warrant ART modification between cohorts, 0 patients initiated on dolutegravir lamivudine needed ART modification due to resistance or HBV co-infection. In conclusion, dolutegravir lamivudine may be a reasonable single-tablet regimen for immediate ART. For next steps, prospective head-to-head studies are needed to definitively establish dolutegravir lamivudine's non-inferiority to BF-TAF when used for immediate ART. Future studies can also compare the efficacy of 2-drug versus 3-drug regimens in the setting of immediate ART.